Hello guys, welcome to our channel. Today we are going to discuss the anesthesia rapid revision lecture as part of our mission 200 plus 1 month, 1 plan, 1 goal for the upcoming examination of the January Fmge 2026. So let's start the discussion, guys. So here in the picture, this person is father of anesthesia. His name is John Snow. Okay, he was the pioneer to start the anesthesia in the surgical field. Next, coming to the grading. ASA grading, this American classification is very important before we take any patient for the anesthesia, whether it is spinal, epidural, or the general anesthesia or the inhalation anesthesia. This classification is very important. So let's see. They are total 6 grades, and in this 6 grade, the first grade is that the patient is completely normal. He does not have no diseases. Okay, this is the first person. ASA grading is the patient is healthy, non-smoking, non-alcohol user, no drug abuser, no other comorbids. He is ASA 1 grade. Next, grade 2, this patient is having the mild systemic disease. This patient is having the mild systemic disease. For example, this patient is, it can be he is a smoker, or he can be the any kind of like asthma, or patient is the hypertension, diabetes mellitus. These mild diseases is belong to the grade 2. Next, grade 3, this patient is having the moderate to severe disease. Moderate to severe disease. For example, the patient is having the same hypertension plus diabetes mellitus, but poor medical compliances. The patient is not taking the medications, or patient is having the recent history of CABG, or patient is having the MI myocardial infarction, or patient is having the CVA. These condition is belong to the grade 3. Next, grade 4. This patient is moribund patient. Sorry, this patient is also severe category. Severe category, and this patient is having the constant threat to his life. Okay. So anytime on the surgical table also, we can see that patient might be dying. So what are those severe heart diseases like valvular heart diseases, or the patient is having the recent history less than 2 months history of the MI or CVA or transient ischemia attacks. All these will be seen in this patient history. Or patient is having the recently surgical valve surgeries or the aortic rupture. These kind of the patients are going to category 4. Next, category 5, this patient is the moribund patient. What does mean by the moribund patient, guys? So this patient is who is not expected to survive without that surgery. So there is a death, but if we are not going to do that surgery, obviously he is going to die. But that surgery is very important for this patient. Okay, not expected to survive without surgery. Okay, this is known for the moribund. Example again, severe intracranial bleed, or patient is having the severe valvular dysfunction. Also patient is having the aneurysm ruptures. Aneurysm rupture belongs to the category 5. And category 6, this patient is already brain dead. This patient is the brain dead patient. Next, moving on to the gases and the cylinder. And this small table is very important, guys. For example, oxygen. So how we are going to see the black body and the white shoulder. And N2O, the nitric oxide, is completely going to be in the blue color. Next, helium, brown color. Carbon dioxide is in the gray color. And air will be opposite to the oxygen. White body with the black shoulder. Cyclopropane, complete orange. Entonox, blue body with the white shoulder. Okay, these points are very important for the examination. Next, coming to the drugs, when to stop and when to start. Okay, when to stop before the surgery. Some of the drugs we can continue also on the surgery. Let's see what are those important drugs that we have to take note. For example, the patient is hypertensive. He can be taking the beta blockers or any other drugs, right? So all hypertensive drugs can be continued. Okay, it can be continued, guys. And diabetes mellitus patient, for this diabetes mellitus patient, what we can do means there is a risk of the hypoglycemia. So for that, what we can do, the oral hypoglycemic drugs or patient who is on the insulin, these patient we can stop on surgery day. Stop on surgery day. Remaining all can be given. Intraoperative also we can give, but during the surgery we have to stop. Intra-op only the regular insulin, very short acting could be given, but should not be given the other drugs. Next, the patients, those who are suffering from the thyroid conditions, right? Thyroid storm risk can be also seen. For this patient also we can continue. We can continue. Next, moving on to the epilepsy, all are going to be the CNS. It is going to cross the blood-brain barrier, right? For this patient also we can continue. Okay, we can continue. But there is a controversy in the hypertensive drugs. ACE inhibitors or the ERB inhibitors or analogs, we should not be given on the day of surgery. Okay, if it is a very major surgery, then we have to stop. Okay, only this point that you have to remember from the hypertensive drugs. Next, anti-tubercular drugs. Anti-tubercular drugs. What we have to do, always we can go for this drug. Okay, we can continue. But at the same time, you should have the LFT normal. Then only you have to continue this anti-tubercular therapies. And also another one, diuretics. Diuretics should be stopped before the surgery, and anticoagulants. Anticoagulants, these are usually avoided, discontinued guys, or stop at least priorly 3 days before. We have to stop because there is a high risk of bleeding, right? That's why anticoagulant should be stopped. So this is the main things that you have to know about the drugs and their when to continue, when to stop. Okay, next coming to the diet. So how about diet? Solids, right? Liquids and also semi-solids. So fasting is very important to decrease the aspiration, right? For all the patients, those who are ideally when there is a solids, if the patient is taking the solids, at least the patient should be taken 6 hours priorly only. From the 6 or before the 6 hours only, she should be taking. Next, coming to the liquids, clear liquids, only 2 hours. Okay, 2 hours fasting is very important. Next, coming to the semi-solids, at least 4 to 5 hours. Okay, this is the diet that we have to follow for the fasting before the surgery. Okay, next, coming to the picture, here you can see this is the neuromuscular monitoring. This is known for the neuromuscular monitoring. What we are doing in the neuromuscular monitoring, basically we are checking the whether the adequate muscle relaxation is there or not. That is, we are going to check this neuromuscular monitoring with the help of train of 4. With the help of train of 4 stimulation. Next, what is the common nerve that we are going to test here, guys? Ulnar nerve. Ulnar nerve we are going to check. And what is the muscle? The muscle can be also asked in the examination. Adductor pollicis muscle. That we are going to check here. Next, another picture here you can see this is known for the bispectral monitoring. What does mean by the bispectral monitoring? Here we are going to check the EEG forms. In the EEG waveforms, we are going to check. Okay, what should be the normal range, guys? At least 40 to 60 should be the normal range. This bispectral monitoring is basically checking the depth of the anesthesia. It is checking depth of the anesthesia when the patient is in the absence of the awareness around him. This is what basically we see in the we are going to see in the patients of the bispectral index monitoring. We are going to see in the bispectral index monitoring for the depth of the anesthesia. All right. Next, here comes the Mapleson circuits. This is the Mapleson A and this is Mapleson B. This is the Mapleson C and Mapleson D, E and F. We have almost all the different types. What are the things that you have to remember? Where these FGF, this is for the fresh gas transmission. And here we are going to place the patient, right? This is how circuits will be maintained. In this, you have to understand what are the important ones only. The Mapleson A is for the Magil. This is known for the Magil type. And Mapleson D, this is as Baines circuit. Okay. What is the difference between A and D? So A is for the spontaneous ventilation. A is for the spontaneous ventilation. Next, Baines is for the controlled ventilation. Controlled ventilation. All right. Next, E is does not contain bagless. Okay. It does not contain the bag. It is bagless. And it is also attached with the air tube. Okay. It is attached with the air tube. So there won't be the valve, and at the same time, there is no bag for this. And Mapleson F, this is commonly used for the children's. Okay. And this is known for the Jackson's. Okay. Jackson's Reeves. These are the important points that you have to use. Most commonly for the adults, we are going to use the D. Okay. D is used for the Mapleson D is used for the adult patients. All right. Next, moving on to the capnography. Capnography is also very important that you have to remember. Let's see how we are going to calculate. Capnography is mainly maintained by the end tidal CO2 monitoring. It have the different phases. The phase 1 is for the inspiratory baseline. Phase 2 is for the expiratory upstroke. Phase 3 expiratory plateau, and EtCO2 is released at the expiratory phase 4. This is for the downstream. This is the importance that you have to see for the capnography, right? Again, coming to the phase 1 is for the inspiration. Okay, inspiration. And phase 2 is for the expiration upstroke. And phase 3 is for the plateau. And phase 0 or the phase 4, this is for the expiration downstroke. Next, some of the examples, let's see here. This is the normal waveform, guys. When we are going to attach, this is how the normal waveform will be presented. Now, here you can see this is for the obstruction. Here, this is a classical picture that you are going to see. How this is seen. This is seen as a shark fin. Okay. This is seen as a shark fin type. Usually seen in the obstructed ET tube or also patients with the bronchospasm. Is seen with these type of the shark fin or the upstroke patterns of the abnormal waveform. Next, another picture. This is due to leak. When there is a ET tube leak, here this is how the pattern will be seen. When there is a flat line of the upstroke will be seen here. Next, apnea. This is going to present as a very delayed type of the apnea or the disconnection from the ET tube will be seen. Next, cardiopulmonary arrest. There will be a decrease of the EtCO2, the capnography is seen. Next, rebreathing. There won't be the completely here as we have seen here in this picture. So there will be a line that will be baseline touching. But in the patients of the rebreathing, so there won't be the baseline touching. That is seen with the rebreathing patient. Okay, these graphs can be also asked in the examination. Next, moving on to the another picture. This is the cannulas, right? Cannulas can be also asked in the examination. How can you remember the cannulas? Remember this way by the colors only. First, below the earth, we are going to see the orange color. Okay, by the below the earth, you are going to see the orange color, significance of the lava. Okay, above that, there will be a soil, gray color soil. And on the soil, there will be a grass, that is green color. Right, grass. Next, above that, there will be a blossoms of flowers. Right, pink color. Above that, there will be a sky, blue color. In the sky, you are going to see the sun, right, yellow color. And above the sky, there will be a last color, violet. Okay, this is normally from the earth when you are coming. Lava, soil, grass, flowers, sky, sun, and above that, there will be a violet color. Now, what are these gauge numbers and how they are sized? And what are the uses? For the gauze color at the 26, this is the used highest. This is the gauze. Okay, the needle length will be more. And when the number is decreasing, the size is also going to decrease. Right? Next, orange is used commonly for the pediatrics. Yellow is also used for the pediatrics. And next, green color one is most commonly used for the blood transfusions. Blue and pink color used for the adult patients. Blue and pink is used for the adult patients. Now remember the gauze number. What is the gauze number that you have to remember here, guys? Orange is for the 14 and gray is for the 16. Green is for the 18 and pink 20. Blue for the 22. Yellow is for the 24. Violet is for 26. Okay. There will be a two numbers. All are going to be the even numbers. That's how you have to remember from the 14 number. This is for the cannula and their size and their uses. Next, coming to the Mallampati scoring. So here in this picture, here you can see the Mallampati scoring is very important to assess the scoring for the intubation in the surgery. So the class 1, where you are going to see the all the normal structure, where you are going to see the uvula and also soft palate and tonsillar pillars, all are going to be the visible in this picture of the class 1. Next, coming to the class 2, in this you are only going to see the uvula, soft palate, but there no tonsillar pillars you are going to see here. No tonsillar pillars are seen in this picture. Next, class 3, you are only going to see the base of uvula and soft palate is seen. Class 4, only hard palate is seen. And in this, class 1 and class 2 can be done for the intubation. And these two is not done or completely contraindicated for the intubation for the patients. Okay, this is the thing that you have to remember. Next, coming to the types of oxygen airways. And in this, these three are very important. The first one is the nasal cannula. Second one is the simple mask, simple oxygen mask. And this one is the non-rebreathing mask. Non-rebreathing mask with bag. Okay, this is how we are going to see. And coming to the nasal cannula, this FiO2 will be, fixed oxygen will be around 0.24 to 0.45. So it carries at least 2 to 6 liters of oxygen. It will carry at least 2 to 6 liters of oxygen per minute. Next, simple O2 mask, it consists of FiO2 0.44 to 0.60 and it contains of 6 to 8 liters of oxygen per minute. And non-rebreathing mask, FiO2 will be 0.6 to 0.9. It contains at least 6 to 10 liters per minute of oxygen for the breathing. Okay, this is for this. Next, coming to the, this one is the classical laryngeal mask airway, right? This one. This is how we are going to place. What is importance of this laryngeal mask? Easy to use and less neck bending will be approached. Okay, but This does not, but this does not prevent the aspiration. Okay, next coming to the prosil. This is the prosil laryngeal mask airway, and it will prevent the aspiration. Next, another picture here you can see, this is known for the Goodell's airway, right? Goodell's airway, and this is known for the intubation, ET intubation. Here you can see this is the Murphy's airway and this is the cuff. Cuffed airway is important because again it is going to prevent the aspiration. Okay, next this is known for the pilot balloon. Picture you are going to see the two types of the laryngoscopes. So one is the curved type and other one is the straight. Okay, this is used for the pediatrics and this is used for the adult patient. And what are the names of this? This straight one is known for the Miller's and this one is known for the Macintosh. Okay, this is for the purely intubation purposes we are going to use. And here the another picture that you are going to see here, this is known for the Venturi mask. Okay, this is known for the Venturi mask, and Venturi mask is going to have the FiO2 0.24 to 0.6, and how much oxygen it is going to carry? More than 12 liters per minute of oxygen it is going to carry. These are the another types of the colors that you are going to have according to the size. Next, last examination, there is another question that is asked with the help of this picture. Okay, so identify this, whatever the graph or the waveforms that is present in the ventilator settings. So remember that this first one is about the pressure, especially for the positive and expiratory pressure. So the peak will be the peak pressure and this is the plateau phase. So there is no touching of the baseline is seen. Next one, coming to the peak inspiratory flow is seen in the flow type, and here you are going to see the expiratory flow also, peak inspiratory flow and at the same time peak expiratory flow. The last one is for the tidal volumes. In between this type is for the inspiratory pause, right? This is how you are going to see. So this is the tidal volume inspiratory phase and this is the peak expiratory, peak inspiratory, and this is about the PEEP. Okay, these are the three types that you have to understand from the picture of the ventilator waveforms. So let's continue with the inhalation anesthetics, and the first classification will be halothane, isoflurane, sevoflurane, and we also have the desflurane. Okay, so colors accordingly, halothane will be in the red color and the isoflurane will be in the purple, sevoflurane yellow, desflurane in the blue color. So coming to the MAG, what is this MAG, guys? MAG value, minimal alveolar concentration. So these minimal alveolar concentration, the more MAG will be equal to, or it is going to decide the potency. Okay, so more the MAG, the potency of the drug will be decreased. The blood gas partition, how this is going to see, if there is a blood gas transition, partition will be decreased. How much the low it is going to increase the solubility of the drug. Okay, so opposite to that, when the MAC is more, the potency will be decreased. When the partition is less, the solubility will be increased. This is the main difference that you have to remember. For the halothane, the MAC will be very less, 0.75, followed by the isoflurane 1.12. Okay, next followed by the sevoflurane 2 and desflurane will be the 6. Okay, this is how it is. Next, coming to the blood gas partition. So halothane will be high blood gas partition 2.25 and isoflurane 1.5, and sevoflurane will be 0.63, and desflurane is 0.42. Okay, again it is going to follow this way only. So the more MAC is present for the desflurane, so the potency of the desflurane will be less. The MAC is very less in the halothane, but potency is high. So that's why halothane is used for the commonly drug. Next, coming to the CNS effects. So usually halothane is contraindicated in the patients of the neurosurgeries, and the most commonly used drug for the CNS patients is the desflurane, and this is the second most common, and third most common is the sevoflurane, right? This is bestly used for the patients of the CNS or the neurosurgeons. Okay. Next, before we go for the cardiovascular, let's see liver. H for halothane, H for hepatitis. It will cause the hepatitis in the patients, those who are taking the halothane. Next, halothane can have the patients, those who are with the liver disease, we can go for the desflurane. Desflurane is bestly used for the patients of the hepatic condition. Again, the second best choice will be the isoflurane. Sevoflurane will be the third best choice for the use of the patients, those who are from the liver disease. Next, respiratory system. This is the most common agent that we are going to use. Sevoflurane is used even for the patients of the asthma. We can use the sevoflurane. Next, another drug that we another drug we can use is the halothane. Okay, this is also the best second most common, and it is also best bronchodilator, and remaining are going to be the very less effects. Next, which is the best cardiostable drug? Again, the most common cardiostable drug will be the desflurane, and second best choice will be the patients, those who are with the heart diseases, especially in the pediatric patients also, we can go for the sevoflurane. Next, why we are going to use the sevoflurane means it has very good smell. Okay, it has very good smell. That's why in the pediatric patient, we are going to use the, especially the sevoflurane only. Next, coming to the which we are avoided in the cardiac diseases is the this both the halothane and also isoflurane. These two drugs should be decreased or avoided in the patients of the cardiovascular system. All right. Next, again, if you have to revise, so the isoflurane is bestly used for the patients of the only CNS patients and the liver disease. Sevoflurane is best used for the pediatric patients, used for the cardiac, respiratory, and all the systemic diseases. Sevoflurane is the best drug. Desflurane is also best for all the drugs except the respiratory system. Okay, remaining all hepatitis is most commonly associated with the halothane. Next, coming to the IV anesthetics. Sodium thiopentane and propofol, ketamine, and also ethomidate. Mechanism of action for these drugs. Sodium thiopentane is the thiopentol is most commonly it is barbiturate. Propofol is going to be phenol. Ketamine is also NMDA receptor antagonist, and ethomidate is the going to increase the GABA action. Okay, GABA receptor action. Propofol is also going to increase the GABA action, and at the same time sodium thiopentol also increase the GABA action. Next, coming to the appearance, propofol is going to look like a milky white, and yellow color will be seen with the sodium thiopentane, and these both are going to be the crystal clear only. Next, how they are going to be the affected on the different system. So remember this way, the sodium thiopentane is going to be the best for the patients with the CNS. This is the best drug for the CNS patient. And next one, another patient also, those who are with the trauma, we can use the propofol as a drug. Okay, but what we have to use should not be used ketamine. Ketamine should not be used in the patients of the CNS. And ethomidate, it is going to be the cerebroprotective. Next, coming to the cardiovascular system. In the cardiovascular system, which drug is the best? The cardiostable is the ethomidate drug. What are the other effects of the patients? Ketamine, again, it should not be used because it is going to increase the BP and the heart rate. And propofol should not be also used because it is completely going to decrease. And sodium thiopentine, it has the both effects. It will decrease the blood pressure and increases the heart rate. Next, respiratory system. For the respiratory system, it has the different types of the effects. One is bronchoconstriction by the sodium thiopentine. Bronchodilation, the both will be having the bronchodilation for ketamine and the ethomidate. Respiratory distress or respiratory depression is seen with the propofol. Next, contraindications. Contraindications, shock patient, we should not give the propofol or we should not give the thiopentane. These drugs should not be given. Next, another disease, heart diseases patient also, we should not give those who are taking the sodium thiopentane. And respiratory conditions, contraindicated drug is the propofol. Next, here, ketamine we already discussed. Those who are with the CNS condition, we should not give. And at the same time, also the cardiac diseases or patients, those who are with the neuro diseases, we should not be given this drug. Next, side effects. Side effects will be the sodium thiopentane will be having the pain at the injection site. Okay, that point should be noted. But the most common pain at the site will be associated with the propofol. Okay, that will be until 48 hours it is going to present. Next, post-operative delirium is mostly associated with the patients of the ketamine. Next, nausea or the vomiting. Nausea, most emetic drug is the ethomidate. All right. Next, another things that you have to remember, indications. For the daycare surgeries, we use the sodium thiopentane, and also we are going to use for the patients of the propofol, we are going to use this drug. And the ketamine, what are the uses of the ketamine? Is usually we are going to use in the patients of the asthma, we can use, and also shock patient where we are not going to give the thiamine or we are not going to give the propofol. There we can use the patient's ketamine. Next, cardio, all the cardio patients, we can use the ethomidate. These are the things that you have to remember. Next, muscle relaxants that we are going to discuss here. In the muscle relaxants, the first drug that you have to remember is the succinylcholine. Okay, succinylcholine, this is the fast and short acting drug. Faster onset with the short acting or the short duration of the drug it is going to have. The most commonly, this will be going to cause the hyperkalemia. Okay, hyperkalemia is seen with the succinylcholine. Succinylcholine, those who are patients with the mostly as another thing that is associated with this one is the malignant hyperthermia. And malignant hyperthermia patients, there will be again sudden rise of the temperature, sudden rise of the heart rate, and also many other causes, and rhabdomyolysis and renal failure is seen in this patient. What is the drug of the choice for this patient? The dantrolene sodium should be given for this patient. This is the malignant hyperthermia. Next, malignant hyperthermia, is it only associated with the patients, those who are taking the succinylcholine? No, it is also associated with the patients of inhalation agents, those who are going to take. Next one that you have to remember, atracurium. And in this atracurium, the most important one is this is the non-depolarizing drug. This is the non-depolarizing drug, and this is going to degrade by its own with the help of the Hoffman degradation. Hoffman degradation. Okay, so this can be given for the patients of those who are having the liver disease or renal disease. We can go for with this drug, cis atracurium or the atracurium drug. Next, third one is going to be the mivacurium, commonly used for the daycare surgeries. Fourth one, bacronium, good for the heart disease patients. We can use, okay, because this is going to be cause the jaundice. So it is should not be used in the patients of the liver failure. Next, rocuronium, use it for the ET intubation patient. During the ET intubation, we can use the rocuronium. These are all going to be the most important points that you have to remember for these drugs. How about the relaxation and how about the reversal? So for the reversal, we are going to use the two types of the drugs, guys. So what are those drugs? Let's see here. So the first one is the neostigmine. First one is the neostigmine. So this is going to provide the spontaneous breathing, but it is associated with the bradycardia. Bradycardia as a side effects seen with the neostigmine. Another drug, sugammadex. We can expect one question from here. This sugammadex is going to be the cyclodextrin molecule, and it is used for all the daycare surgery reversals. Daycare surgery reversal. Side effect is it is going to have the anaphylaxis reaction. So testing dose should be given before we administer the main drug. Next, we are moving on to the local anesthesia. Okay, so the local anesthesia, the main mechanism is it is going to block the voltage gated sodium channels. Okay, so the NEA channels are going to be blocked. So what happens? There will be completely action potential will be decreased. So this will lead to the loss of sensation. Loss of sensation. Common one that we are going to see is the lignocaine. Commonly we use in the COTs and all the dressings that we are going to use. And this lignocaine is going to contain the amino amides. Okay, what happened when you give the regional block? This will be worked as a regional block, but lignocaine have its own side effects. So basically, when we give the lignocaine for the intravenous regional block, it is going to affect the cardiovascular system. How? Because when they block the sodium channels, it can aggregate and disturb the action potential of the ventricle. So that's why it is contraindicated in the patients of the hypertension, coronary artery disease, and also endocarditis. This patient, we are not going to give the lignocaine. What for the cardio patients, what we can give? Bupivacaine. Okay, bupivacaine can be given for the heart disease patient. Okay, bupivacaine can be given. Next, dupivacaine. Sorry, dupucaine. This is for the most potent and most toxic. This is the most toxic. Okay, done with it. D for done, D for dustbin. You should not be used this drug. Next, also we have the IVRA agent. This is used for the limb surgeries. Used for the limb surgeries, but it should not be given for the patients of those who are having the vascular diseases. Next, coming to what are the side effects that you have to remember for the local anesthetics. So usually what happens when you give the local anesthetics, we already remember that it is going to stop the block the action potential, and also it is going to cause the voltage gated calcium channels block, and numbness we are going to get, and also absorption will be decreased by this drugs. So whenever there is a last, what does mean by the last? Local anesthesia systemic toxicity, especially CVS or the CNS or metabolic acidosis. What is the antidote that you have to give? The antidote of this patient, we should give the 20% lipid emulsion therapy. 20% lipid emulsion therapy should be given for the patient. Okay, that is the one thing that you have to remember. Next, another question also can be asked in the examination. What are the drugs that are associated with the methemoglobinemia? So methemoglobinemia is associated with the prilocaine and benzocaine. Okay, these two drugs are associated with the methemoglobinemia. Next, moving on to the spinal anesthesia. Before that, we have to understand how it is pierced. First, it is going to enter the skin, followed by the subcutaneous tissue, and then followed by the supraspinatus ligament. Okay, supraspinous ligament, followed by the interspinous ligament. Okay, it is interspinous ligament, followed by ligamentum flavum, and then it is going to enter the epidural space. From here, dura mater, and then arachnoid mater, and followed by the subarachnoid space. Right? Already you are going to reach the spinal. This is for the spinal anesthesia. See clearly again, first skin, then subcutaneous tissue and spinous processes. Right? This is the supraspinous ligament and interspinous ligament. Next, ligamentum flavum, and then dura mater, and again it is going to enter into the subarachnoid space. And what is the best where we are going to do this? At the L4. Lower of the L4. This is we are going to see exactly the position that you are going to use. What are the needles that you are going to use? Tuhoy needle, and another one is the Quincke needle. Okay, Tuhoy and the Quincke needle that we are going to use. And how about the side effects that you have to remember for this one? The side effects are commonly associated with the spinal anesthesia is most commonly hypotension. And there is another one also, post-dural headache. Post-dural headache 12 to 24 hours after the block that you are going to experience. What we can give for this patient? We can go for the caffeine, or you can also give the NSAIDs. And for the epidural spinal anesthesia, epidural, obviously it is not going to enter the arachnoid mater. It is only going to enter here until the epidural space. And whatever the toxicity, that dura puncture is going to happen only in the spinal, not in the epidural anesthesia. And another things that you have to remember, the level for the any patients for the spinal, we are going to use the L3 and the L4, L5 only. For this patient, epidural anesthesia usually done for the cesarean sections. So it can be done at the same position, L3 and the L4. That is for the patients of this one. Next, more commonly associated hypotension with the spinal only rather than the epidural anesthesia. These are the important points that you have to take note when you are having the anesthesia briefing. These points and almost all are the PYTs only. Take note and practice these MCQs and tonight's 50 questions quiz. And those who are new to this channel, please do subscribe and share with your friends.